All right, so today we're going to talk about COVID-19 update, the global, national, Idaho, local, what we're experiencing here at Kootenai Health. Talk about the vaccines, facts and stats, and then also what we're seeing with the Delta variant. Then we'll get to the commonly asked questions and some live question answer session at the very end. So
globally, I think everyone by now understands that this has been unbelievable past 20 months. There's been over 200 million cases of COVID-19 across the world, over 4 million deaths. New cases in the last 24 hours, this was information pulled about 24 hours ago, 461,000. And then new deaths topped 8,000 in the last 24 hours globally. Nationally, we've seen similar patterns, 35 million cases diagnosed in the United States, 617,000 deaths up to date as of yesterday. In the last 24 hours, 91,000 new cases, and the new death numbers have been also increasing, 495 deaths in the last 24 hours.
Again, in the United States, 35.5 million people infected. India, which has had a big outbreak and where the Delta variant they were hit hard by the Delta variant, 31.8, and then Brazil as well at 20 million. And if you look at the next 6 countries, they're still less than the United States, 34.7 million infections reported. In Idaho, we've had about 205,000 total cases, and within the last 24 hours, 626, and then total deaths since the beginning of the pandemic, about 2,217.
If we look at Kootenai County and kind of break it down for our local, a little over 20,000 positive cases. As of 2 days ago, 225 deaths. We've had another death since then, so we're at 226 deaths. It just wasn't reported.
Currently, actually, I think 70 this morning, 72 or 71, 29 in critical care, and then our 7-day positivity rate. This is what Kootenai Health tests has been. 28% of the tests that we've sent have been positive for COVID. We've been tracking data from the very beginning. We've had 1,700 total admits. Currently, actually, I think 70 this morning, 72 or 71, 29 in critical care, and then our 7-day positivity rate. This is what Kootenai Health tests has been. 28% of the tests that we've sent have been positive for COVID. That's one of the highest numbers we've seen during this whole pandemic. And this is the data that we look at on a regular basis. As you can see, back in July, we had about a 7% positivity rate, and we've seen it increase over the last 4 weeks significantly up to where we are now. And that's gone along with an increase in the hospitalizations. So back in December, January, hopefully everybody can see this, the gray bars show our positivity rate, and our admissions to the hospital closely follow that positivity rate. And we're seeing the same thing now with an increased positivity rate leading to increased admissions, both to the acute care side of things and then also to the ICU.
And I think this graph is telling also because if you look back to the middle of it at what was our previous peak in December of 2020 and January of 2021, we are fastly approaching that day by day. And I think our biggest concern is that we're going to not only approach but exceed it in the next short time frame. This is something that we should all pay attention to. This is a description of the average age of our COVID-19 admitted patients to the hospital. And the blue lines represent patients 18 to 60 years old, and the orange line represents patients 61 to 80 or older. And what you see is beginning back in December, the average age of our admitted patient began to basically fall, meaning the blue line was rising because we had younger and younger patients in the hospital. At the same time, the average age of the number of admissions, rather, of our older patients began to decline. And we now are at a point where those lines are getting ready to cross, where our younger patients will exceed number of admitted of our older patients. So early on in this pandemic, there was a lot of talk about this being a disease of the elderly. That certainly may have been the case, but we are now seeing this as a disease of the hospitalization of the younger, 40s, 50s, and 60s is what we're seeing admitted to the hospital now.
So we'll talk a little bit about the vaccines that are available in the U.S. You have two mRNA vaccines, the Pfizer and the Moderna, and then an adenoviral vector vaccine, the Johnson & Johnson. The efficacy of these three vaccines, when studied for approval for the emergency use authorization, showed an efficacy of 95% for the Pfizer, 94% for Moderna, and then 85% for Johnson & Johnson. Both the mRNA vaccines are two-dose vaccines, and the Johnson & Johnson one was marketed as a one-dose. The time to effectiveness for all these were about 14 days after the second shot, where you got to that high efficacy. They're approved, the Pfizer for greater than or for 12 and older, and Moderna and Johnson & Johnson are both approved for 18 and older.
Just a brief refresher, we talked a little bit about this in December with our first WebEx, but just to remind everyone what an mRNA vaccine is. The mRNA is a set of unique instructions that the body uses to produce proteins. It's a instructional process that's used by all cells, not only by humans, but also animals and viruses. There's big benefits to using mRNA for the COVID vaccine. Particularly, it allowed for a rapid development and manufacturing so that we could have millions of doses available quickly. It also doesn't contain eggs or mercury for people that have allergies to those elements. And then also it allows for a very precise determination of the vaccine target. In this particular case, the target is the spike protein. The other part about mRNA that is fascinating and also very important for this pandemic is that it's easily adjustable if needed. The ability to change the sequence of the instructions that's included in the vaccine can be done. It can be done fairly quickly, and it can be scaled up for distribution if needed. The other part about mRNA vaccines that we get asked frequently is that they feel like they're very new. And this has been a topic that's been coming around back to us multiple times. And the idea and the concept behind an mRNA vaccine is actually not new. This technology has existed for over 30 years. It's been studied for those 30 years. It actually has been utilized to create vaccines for other viruses. The flu was one. Zika virus was another. Something called CMV was another technique that they used it for. The situation that arose, however, was that there really hadn't been an urgent global need to have this technology available because of a pandemic. So when the COVID-19 pandemic began, it became evident to the scientists that had studied this for 30 years that this was a way that we could create a vaccine that would be helpful in a short fashion that could be adjustable and scaled up as needed.
Yeah, and I'd also say, I mean, from a molecular biology standpoint and immunology standpoint, if you were going to design a vaccine and do it the way that makes the best sense from that standpoint, from molecular biology, immunology, this is the cleanest way to do it. It's the simplest way to do it. It's using what technology that we can do in the lab and transfer easily into a vaccine and then give it to humans fairly quickly. I get the question, you know, aren't you worried about how fast this happened? And after doing years of molecular biology, that's my background. I was actually more concerned at how long it took to get it out. I wanted it faster because, from my standpoint, this was the way to do it, the cleanest and simplest way. So I think that they did a great job and went overboard some in their safety look at it. It was very, very, it wasn't quick to me. It was a little bit slow. So talking about viral vector vaccines, this is another technology that's been around for a long time. If you work in a lab and work in cell culture, you've been using this for a while, animal models and those kind of things. You use an adenoviral shell to get the DNA, the coding for the spike protein, into the cell. And it's just using that shell of a virus. It's not a full virus. It's a shell. It's a couple proteins that allow that shell to get into the cell and then get the spike protein replicated. So, and then you get the coronavirus spike protein expressed on the outside of the cell, and that allows the immune system to recognize it and develop antibodies.
Yep. So a couple of kind of touch point factors that are important to understand about these about these vaccines rather. There is no live virus from COVID-19 in either vaccine. There is no possibility to acquire an infection of COVID-19 from either of the vaccines. The mRNA that's in the Pfizer and the Moderna vaccine is actually eliminated from the body in about 72 hours, but its job's already been done by that time. The mRNA codes for the spike protein that's on the surface of COVID-19. It does not enter into the nucleus, and therefore it cannot alter your DNA. The spike protein is something that's easily recognized by the immune system, so you can generate effective and robust antibodies. And I think that's really the biggest point of these vaccinations, is that this is a multi-layered immune response. It's something that your body can generate antibodies quickly, but you also generate what are called memory cells, which is the library of the instructions, so that if you do encounter the virus in the future, your body can make antibodies quickly again.
For a second, they lost the slide. Just a reminder to everyone to turn off their video if.
I think we saw Joe Bowen log in. That's the problem.
So again, just turn off your video, everyone.
All right. All right, you want to talk about side effects?
So we understand that there's a lot of discussion about potential side effects from any medical treatment, but particularly that have centered around COVID-19 vaccines. So we wanted to talk a little bit about a few of the side effects that have been reported in the media and help bring a little bit of light to the incidence of these. So there's been over 346 million doses given in the United States. Globally, there's been over 4 billion doses of vaccine given. The trials that studied the mRNA vaccines included tens of thousands of participants, about 40,000 in each trial. Since deployment of the vaccine nationally and internationally, there's been the most intensive and ongoing safety monitoring program that we've ever seen in U.S. history. As a result of that, the monitoring system actually identified 2 potential issues. The first one was with the J&J vaccine, a condition known as thrombosis and thrombocytopenia syndrome. It's a condition where people can form blood clots. This was found to be in 0.00031% of the doses given, a very, very small number of the total doses administered. The initial discovery of this occurred after the first 5 or 6 potential reports into the vaccine monitoring system, which really speaks to how robust that system is, because it was able to pull out those 6 case reports and then begin to expand their search to look for others. In the end, they identified somewhere between 15 and 19 potential cases. There seemed to be a trend towards women under the age of 50. So the current recommendation is to have consideration as a potential risk factor for younger aged women for the J&J vaccine. The vaccine was paused for a brief period of time until they could sort this out. And once they determined that it was not a risk factor that warranted cessation of this vaccine being distributed, it was restarted. So we'd like to, in full disclosure, bring that forward. The other situation that you will see and read about is with the mRNA vaccines. And that's a condition called myocarditis and pericarditis. So myocarditis is the heart muscle. It's inflammation of the heart muscle. Pericarditis is inflammation of the sac that the heart sits inside of, kind of like a grocery bag. Again, a very, very small incidence of reports, 0.0056% of doses. Remember, 0.001 is 1 out of 100, so we're getting down into the 1 out of millions type of dosing range here. This occurred mostly in adolescent males, 16 to 20 years old. The vast majority were treated and returned to normal activity. Again, this was not a reason to stop vaccination. It was a reason to be aware of the safety process that was in place to identify a potential issue, to address it, and then to make sure that the warnings were at least placed out so that people were aware of them. We know that the vast majority of side effects that are going to be reported after a vaccination will occur within the first 6 weeks of a vaccination. So the idea of having a side effect from a vaccine 3 months and 6 months later really does not fall in line with the way vaccination works. They're still doing ongoing monitoring of all the patients that were in the original trials. So the Moderna and the Pfizer and the J&J trial, they still circle back with those patients on a regular basis, or those trial subjects on a regular basis. And again, this is the most monitored and most scrutinized medical intervention we've ever seen in U.S. history. The amount of data collection that's surrounded it has been massive.
So vaccination rates in the U.S., 58% of the U.S. Citizens over age 12 are fully vaccinated. In Idaho, it's 46%. And you can see for the counties, it goes in North Idaho, it's significantly less. 39% in Kootenai County.
This is a slide we'll take a little bit of time to talk about. This is looking at our employee vaccination rate. The top line is our employed providers. So those are our MDs, our DOs, our PAs, and our NPs. 87% are vaccinated. Looking at our non-provider employees, this would include everyone from the nursing staff to registration, to financial, to the cafe, you name it, everybody else that makes up this institution falls into that category. So looking at our employee vaccination numbers, we're sitting at 45%, so less than half. Overall, as an institution, we sit at 47%. You can scroll down and see that U.S. age 65 and older is 80%. Idaho age 65 and older is 75%. Kootenai County sits at 42%. So as a healthcare institution, we barely exceed what we see in the county population, but we are significantly behind what we see for the older population across the country, the people that we're charged to take care of. So we wanted to make this data kind of transparent and so that everyone could see it. I think it speaks highly to the fact that the provider staff that are being asked to make medical decisions on a daily basis believe strongly in the vaccine. As a result, they have lined up and been vaccinated at overwhelmingly high numbers. And we see that across the country. 85 to 95% of providers across the country are vaccinated.
I wanted to talk a little bit about the Delta variant, which is what we're seeing right now. It emerged from India back in October and first detected in the U.S. back in March. It's now the predominant strain throughout the U.S. We send virus from testing here to the state lab on a daily basis to get sequenced, and that's what we're seeing now. Highly contagious, nearly twice compared to the previous variants. If you're interested in the R0, it's predicted to be that the R0 is 6 to 9, and whereas the original virus was an R0 of 2. So that means one person infected would infect 2 people, whereas with the Delta variant, it goes from 6 to 9. It causes a more severe illness in the unvaccinated individuals. And then vaccinated individuals were seeing breakthrough infections. It's usually a shorter infectious period and less severe illness. So you can kind of see the timeline, the proportion of Delta variant detected by the Idaho Bureau of Labs from April, May, and June into July. And so we can see that it went up from almost non-existent back in April, May, to 81% on the latest testing. So we're seeing a significant rise in our infections here due to the increased infectivity of this virus, and we're seeing an increase in hospitalizations. And this is what it looks like. That's that R naught. Whereas the original variant was an R naught of around 2. Now we're doing 5 to 9. So you can see how one person can infect significantly more people a lot faster. And that's what we've seen. We've seen whole families infected, whole households. Somebody goes to a gathering, either a family or friends, everybody's sitting around the table, and one person unknowingly, I hope, brings the virus in, and then everybody around the table is infected. And it's pretty impressive. It's not like what we saw before in December and January, and it's a much more rapid infection, and appears to be more severe for those who are entering the hospital.
This is some data collected by the Idaho Department of Health and Welfare, and it's very telling. So looking back through July 15th, this is data up through a month ago. 95% of the cases in Idaho were not vaccinated. Looking at hospitalizations, 95% of the people hospitalized at that time were not vaccinated. 94% of the deaths were in people that were not vaccinated. And so part of the reason for this talk today is to try and explain some of the information that surrounds these numbers. These numbers are not meant to scare you, but they're scary. We know that your risk of having a severe infection is reduced substantially, and this shows it by being vaccinated. Your risk of being hospitalized is reduced substantially. Frankly, your risk of dying is reduced substantially by being vaccinated.
So we'll get into some of the commonly asked questions, and we can talk some more about some of this and what we're seeing on our unit here. Can I catch COVID-19 from the vaccine? No, there's not a full sequence of the virus in the vaccine. It's just one part. There's just not a way that it can do that. The other thing I've heard as well is that it can pass the protein on to other people for some reason, and that also that doesn't happen as well. If I had COVID-19, should I still get the vaccine? The recommendation is yes. I think natural immunity is good. I think that, as we know with other viruses, there's a virus change such as this Delta, we're going to see reinfections, and that's what we've seen. We have seen people reinfected and admitted to the hospital. I think that the vaccine gives you a good boost. It's kind of an insurance plan, and it's free. So get that insurance plan, and then you don't have to see us in the hospital. People are unlucky, and you could have had COVID back in the beginning of the pandemic, or you thought you had COVID, but the vaccine will hopefully get your immune system to where you're not going to end up in the hospital. Why should I wear a mask again? Again, this is a much more infectious variant here. The Delta variant is highly contagious. This is because of its increased binding to the ACE receptor and changes in that surface protein. So the mask better protects from all the COVID-19 virus strains. And so it's an easy way, simple thing to do. And I know a lot of people have feelings about that, but and pretty strong feelings, but I'd rather not get sick. Sorry, I just like to be healthy and not have to be in the hospital. And some of the stuff that we've seen in the clinic, I'm really just trying to avoid this. And it can also decrease your risk of giving it to another person, which I also think is really important.
We want to spend a few minutes talking about the COVID mRNA vaccine and the question of infertility. This has been the pre-submitted questions, probably the #1 question that was posed. We think that spending some time unpacking this a little bit is important. We know that it's a primary concern for many, many women. We want to tell you a little bit about where this idea came from, and by idea, I mean theory. So in December, there was a German scientist and another gentleman that paired up and claimed that the spike protein instructions were, in his words, quote, similar to a protein that's found in the placenta of mammals, syncytin, or syncytin, you could say it. He speculated, and again, this was speculation, that the antibodies from the vaccine would attack the placenta and reduce fertility. This has not been proven. He did not prove it. It has not been verified by actual validated scientific studies. There's a couple of problems with his theory. There really is not enough similarity between the mRNA sequence that is in the virus, or I'm sorry, in the vaccine, pardon me, and this protein to make a match. You have to match these things up, just like a puzzle piece matches to its adjoining puzzle piece. There's not enough puzzle piece alignment to do that. The second problem with this theory is that the placenta only forms after a woman is pregnant. So if there was an antibody produced to the placenta, it cannot cause infertility because the placenta has already formed. There has been no identification of pregnancy loss at an increased rate in vaccinated women. And then also, if this was true, and again, this is a theory, but if this theory was true, then women who have been infected with COVID-19, people who have caught the infection, would now become infertile because their body would have formed natural antibodies to the spike protein. So our hope is that these three elements of kind of rebuttal make sense. But there's other information. If you look at the Pfizer trial, there were 23 women who became pregnant during the study. 12 of them were in the vaccine arm, and 12 of them were in the, or 11 were in the placebo arm. There was no loss of fertility amongst the millions of vaccinated women that have come on after the vaccine has been released. It's still recommended to be vaccinated if you are a young woman by the National Women's Medical Societies, the OB-GYN societies, the fertility societies. Pregnant women are at a markedly increased risk of severe illness and unfortunately death if they acquire COVID-19 during their pregnancy. We realize that this is a very difficult topic, and it's a very important topic to so many people that work here. We feel strongly with the national and international medical societies that are recommending this, that they understand what they're recommending. We understand the science behind it, and we hope that hearing more from either your doctor or from us helps with that decision.
Yeah, I would just say, you know, this theory, it was surprising to me when I heard it. It really doesn't make a whole lot of sense from an immunology standpoint. If you get infected with COVID, you make the same antibodies that you do to the vaccine. So we haven't seen anything to suggest that women that get COVID are infertile. So that just doesn't make a whole lot of sense from a scientific standpoint.
Do I need to get a COVID booster shot? We don't know the answer to that yet. Ongoing studies are still occurring to determine if and when a booster shot will be needed. I think that it's possible. More information will follow on that. The idea behind a booster shot is to give the immune system an additional kind of jolt, so to speak, to make additional antibodies. And so it does make sense that the possibility of a booster shot will exist. We'll know more about that, I suspect, in the next 4 to 12 weeks, which then also kind of falls into the idea of, do you have to get a vaccination every year? Again, we're not sure about that answer yet. It really depends on how prevalent COVID-19 still is 6 months to a year from now. They're still following the original trial participants as well as other people who've received vaccination to monitor their antibody levels. We're determining their long-term immunity benefits, and determinations will be made from there about whether yearly vaccination is going to be necessary and indicated.
And they are developing a shot for the Delta variant through Pfizer. I think that's in clinical trials right now with Pfizer. You know, my personal feeling on this and what I've read is that we probably will have a booster shot. They are trialing it also in Israel with their older population there. And so I think it's a good chance. So we talked about, we don't know if you're going to need it every year. It'd be nice if we wouldn't, because everybody would vaccinate and we get rid of this virus. And is the vaccination mandatory to work at Kootenai Health? Not at this time. It's available to all employees that want to be vaccinated. I would say that every major medical society has recommended vaccination for all healthcare employees, including the American Medical Association, the American Academy of Nursing, American Academy of Physician Assistants. The list goes on. So it's a long list of societies that are recommending it across all specialties.
So what can you do to try and stop the spread of COVID-19? We think that first and foremost, virus prevention strategies are important. Masking, social distancing, hand washing. Fourth bullet point, get vaccinated. Encourage others to do the same. We've tried our best to show some data that explains the relevance and the importance of vaccination, tries to allay some of the fears around vaccination. We ask you to stay informed through informational sessions like this about the COVID-19 vaccine. And really, we ask you to inform your families to do the same. You are healthcare workers. People look up to you. People look at you for information. We think it's your duty to give them the most accurate information that you can. Additionally, it needs to be reliable. It needs to be information that's from a trusted source, not only for yourself, but for your friends, your coworkers, and your family. And then I think the last point, number 4, is really, and this has been challenging for the entire institution, but Kootenai Health is still an inspiration to our community, and we ask you to continue to do the same. This hospital has been met with big barriers to the care of large numbers of patients. We're seeing the same happen again, and we really need everyone here available, working, doing whatever their job may be so that we can do our job as well. I think we're going to take a minute. We're going to jump to questions. We have about 20 minutes left, but we want to talk real quickly about vaccine hesitancy among healthcare workers. There are some nice published studies that have kind of boiled this down to 4 reasons that people in the healthcare environment have not wanted to get a vaccination against COVID-19. And I've listed them here: safety and efficacy concerns, preference for post-infection immunity, personal freedom, and distrust. We're going to unpack these just briefly. We don't have slides that follow them. This is a little more of ad lib, but let's first talk about safety and efficacy. Our hope is that through today's talk, we've allayed some of the safety fears. We certainly hope that we've shown you some of the efficacy information. These are vaccines that, in our opinion, we feel, not just opinion, but in fact, are safe. They're efficacious. When we have a vaccine that can prevent a large number of hospitalizations for an illness such as this, we're very much in favor of that. As you know, we have been working with our group and the hospitalist group and the entire hospital staff taking care of COVID-19 patients, and we see this as a safe and efficacious way to try and reduce that volume of patients and frankly, the suffering that we see on an everyday basis.
Yeah. I think that, after you've been infected with COVID-19, and a lot of people have, I think to think about, most people I know don't want to get it again. If you had a mild course of it, and that's good. But most people I know who've had a pretty serious course of infection, they think, a lot of people think that immunity is enough. But I think that again, having an insurance that you're getting a safe way to have even more immunity so it doesn't happen again is really important. The virus is good at suppressing your immune system so that you don't develop as good a response. That's one of the ways that it gets people into the ICU, is that it messes with your immune system and we don't see the appropriate response. So it does that even less, and we'll get more data on that, especially as the virus changes. I think that the immunity that you get from your initial infection is probably going to be less. Personal freedom. I'm all for personal freedom. I'd like people to make good decisions, and I like people to make informed decisions. I think a lot of the stuff out there, information-wise, is I'll be honest, that if you're getting your information from Facebook and Twitter and some of these different websites, probably some of it may be good, some of it may be bad, but I think it's all confusing, especially if you don't do this on a regular basis. We've been looking at medical literature now for a long time, and I think that it takes a long time to be able to navigate through medical literature. There's a lot of people who publish studies out there that are just publishing to bad data, and they're publishing for different reasons rather than to move medicine forward. But I think that personal freedom is important, but there's also an obligation to our community and to our patients to decrease the risk of infection, and vaccination is one of those.
Trust is a big part of this. We understand that there's a sentiment of distrust in governmental organizations, health organizations. I think that our feeling is we're willing to sit here in front of you today and ask you to trust us. Come to the hospital with a pneumonia, you trust us to choose the right antibiotic. If you have a major surgery and you come out of the operating room on a ventilator, you trust us to know how to take care of you on the ventilator. We feel this is a similar trust issue. We would not recommend this to family, friends, co-workers if we didn't trust the information that we have available. So I don't know what else we can really say short of that. We feel that strongly that we're willing to sit here in front of the entire organization and ask for your trust as we do that.
So a couple of the questions we got prior, and we thought we'd go over the breakthrough infections. A lot of people like, why bother getting the vaccine if there are so many breakthrough cases and variants expected? Well, I think that we are seeing breakthrough cases with this Delta variant. We hadn't really seen that with the previous variants, but we are seeing that with Delta. The vaccine is still been very good at keeping people out of the hospital. Not 100%. We will be quite honest with you. We've had 9 patients who have been fully vaccinated in the hospital out of almost 100. So that's about 9%. The vast majority of patients are unvaccinated. Some of those patients of those 9 are people who are immunosuppressed and transplant or have other issues on medications. So they're not unexpected. And from the very beginning, this vaccine was not thought to be, was never promoted as being 100% effective. And I think as we see these variants change, that's where the boosters may come in, is that they may just be able to make either get the immune system up higher so that it's more effective, or change it to where we get better identification of those variants. Anything else on that, or?
I think that's the biggest. We do know through some interesting studies, some of which are new just in the last 10 days, that the antibody response to the spike protein, you actually generate antibodies that bind to the spike protein in multiple different locations. Whereas what's been shown in a natural infection where you make your own antibodies, you may only bind to the spike protein in 1 or 2 places. So the way the virus decides to propagate and become a variant is it changes its spike protein so that your antibodies don't recognize it unless you've been vaccinated. And that's where we see the big difference, is that the vaccinated antibodies can find other sites on the spike protein that the virus has not had time to change yet.
About this one, I've never been offered the chickenpox vaccine after getting the chickenpox. Why is this different? I think that it seems that we have more data on the chickenpox vaccine, and also the chickenpox doesn't change as much as what we're seeing with the COVID. So viruses, not all viruses change and get better. Chickenpox has been fairly stable for a long time, so one vaccine seems to do really well. So and you get a good immune response to it.
Yep.
Is it safe for my child to get a COVID-19 vaccine? All the trials so far in kids have been shown that it's been very safe. I have no issues with children getting the vaccine. They're safe, they're effective. Pfizer is for children 12 and older,
and they can't catch COVID-19 from the vaccine, which we've talked a lot about.
Yeah. Crisis levels of care is what we can constitute moving into crisis mode at the hospital. I think it's when we have so many patients, we outstrip our resources. And this is a discussion that we have right now on a regular basis as we have more and more COVID patients coming into the hospital. We are concerned at some point that may happen. So we try to manage that the best that we can. One of those ways is by decreasing or stopping elective surgeries and trying to only do urgent and emergent surgeries. It's redeploying our staff so that we can take care of more and more patients that are coming in.
And it requires lots of communication at the state level, notifications about trends and concerns and resource availability. It's not an easy decision to make, and it's one that requires lots of input before you get to that point.
It's a very complicated process, requires lots of meetings. So, all right. Why hasn't the COVID-19 vaccine been approved by the FDA, and what is the process? Any approval by the FDA takes a lot of time, and the FDA is going to approve the Pfizer vaccine here shortly. They have enough data, probably more data than almost all the other drugs. So it's just mainly, I think, they had it out for EUA, which they felt was enough, and they will most likely approve. It's much safe. This vaccine has been proven to be much safer than a lot of other medications that have been approved by the FDA. So I don't think that that's going to be an issue.
So great question. I'm fully vaccinated. What more can I do to protect myself from the Delta variant? You've heard us say that the Delta variant has had breakthrough cases. Our patients that we're seeing that have had breakthrough cases, we're very saddened by that. We certainly don't want that for anyone. We feel that one of the number one ways you can prevent yourself from getting the Delta variant after being vaccinated is the social distancing and masking discussions and requirements that we've talked about for a long time, particularly in public spaces where you're with people that you do not know. You don't know their vaccination status. You don't know their infectivity status. You don't know if they just coughed out a cloud of COVID that you just breathed in. That's probably the most effective way. Other steps beyond that would be monitoring the upcoming data releases regarding potential boosters and whether we're going to need a booster vaccine. Being vigilant with your own self and your health is important, but I think also discussing it with your family, your friends, your social circle. The last thing you want is for someone in your family to bring it to you and then have you become infected as well. We've seen that over and over and over again. The vast majority of our patients in the hospital now have a spouse or someone else in their family that is homesick with COVID-19 at the same time, and in some cases in the hospital at the same time with them.
Yeah, we have a lot of spouses, husband, wives in the hospital at this time, and some pretty sick ones. So I think we kind of touched on this. If I've already had COVID-19 and recovered, do I still need to get a vaccine? Recommendations, yes. Natural immunity is great, but we're not sure that it's going to be as effective because the vaccine or the virus will depress some of your response. That's what viruses do. And then it's more of an insurance policy is the way I think about it, so that you don't have to get it again. Gives you a boost. We talked about pregnancy. This is about menses and menstrual cycles. fertility issues. So
I think we've touched on that as best we can, understanding that it's a very difficult topic for lots of people to discuss. I see the question of do no harm. As you know, as physicians, we are tasked with taking the Hippocratic Oath at the time of graduation from medical school. It's not taken lightly. It's an important part of your final 4th year of your medical school training before you go to residency. The concept behind do no harm also follows with the idea of do the best you can, help the most people, eliminate suffering, prevent death. And that's why we talk about this with such earnestness, is that we do not feel that we're doing harm by recommending the vaccine. We think we're actually, and we hope we are, preventing the idea of suffering, illness, pain, and death.
and I'll tell you that we've definitely had a few pregnant women in the ICU with COVID, and it's we don't like to see pregnant women in the ICU at all, and it's tough to take care of those patients, both emotionally, make sure you're doing the right thing for them. It ramps up your it's tough. So, but we do recommend it.
Oh, that's a good question.
Are we seeing the same symptoms in patients that have the Delta variant as the original COVID-19 variant? Yeah, I think we are seeing the symptoms. I think that the onset from exposure to onset's quicker, and we see them ramp up faster. So before they would come in the hospital and spend a few days maybe in acute care, and then their breathing would get worse and they ended up in the ICU. I think that happens in like 12 to 24 hours now after admission in many of these patients. And so I think that the onset to getting sick is pretty fast. So,
and we're seeing a much longer period of severe illness.
Yeah.
Instead of 5 to 6 days of severe illness, we're seeing 2 to 4 weeks of severe illness.
Yeah.
And I think that's the bigger problem, is to be critically ill for 2 to 3 weeks with respiratory failure, dependent on a ventilator. Other body systems begin to fail no matter how well we can do our job. And that's where Delta variant has proven to be a problem. It spreads faster, seems to be meaner, more aggressive, and more difficult once it gets in and infects someone. And that's why, frankly, we're very worried by it and continue to be worried by it.
All right. We have some more.
I think we might have a couple. We got 5 minutes for any that
I can ask you some here. So someone asked, how can we identify which strain the affected patients have, and are we tracking those infected and what their severity of infection is?
So we haven't had that ability as of yet because we send it off to the state. The state does the sequencing. So, and I don't understand the process because we've asked, but they can't get it back to a patient level for us. But I think they're working on that. But we don't. Right now, we don't have that data.
I need to answer a text question that was chatted in. It says that I said the Delta variant is meaner, but I've seen patients with very mild cases. That's good.
Yeah.
You don't work in the ICU. That's the honest truth. We work in the ICU. We've been there since March of 2020. We've seen this. This is a different strain, a different variant of this virus.
Yeah.
And it is ripping our patients to shreds.
Yeah.
I'm finishing my 4th day in a row, and I have only had 3 people in 4 days that have gotten better.
Yeah. I think I try to remind people that the viruses are it's all about numbers and percentages. 80% of people who get COVID are going to do just fine. They're never going to see the two of us in the ICU, or they're never going to come to the hospital. The 20% that get moderate to severe disease are the ones that we're really trying to protect with vaccination. And so only 8% of people or so get admitted to the hospital, maybe even a little bit less, but it's about numbers. So right now, I can tell you that I've worked, I've been doing and attending for over 12 years now. I did a 7-year residency and fellowship and this stuff. I've worked a few, that'd be like 19, 20 years in the hospital through multiple flu seasons, other kind of pandemics, H1N1. I've never seen anything like this, and it's just sheer volume. Remember back in the beginning of this, when we shut everything down, is that we were doing that to preserve our hospital resources and our healthcare resources. And we're back kind of where we were then. We never saw it initially. We didn't see it until July, but that's what we're trying to prevent with immunity and vaccination is these people who are now sitting in our ICU, 30 of them today. Could be 35 tomorrow. I hope not. I hope that that doesn't happen. I'd like to see the numbers go down. I can tell you we're tired of it. We're tired of taking care of these patients. It's really emotionally draining taking care of these patients. So what's the next?
There's one that, so you may want to clarify because someone is asking if there's no way to identify the strain, how can we say that it's Delta spreading?
Oh, well, they take all the strains, and so they do sequence them, and so we send all the samples down there, and they do sequence them. They just don't keep track of which patients it's associated with. So they'll take a nasal swab and they'll sequence the virus from that, and it'll be the Delta strain. And so they report if they get 20 swabs and 19 of them are Delta, so that gives us how many people are getting the Delta.
Because my understanding is from Panhandle Health District, they've heard like of the swabs sent to the state lab, nearly 90% of them are
Correct.
Have been Delta.
9 out of 10 are coming back as positive for Delta.
There's some questions about studies. Some people are saying there's not enough studies surrounding COVID, but you touched on this a little bit in your presentation.
There's more studies on COVID at this point than almost any other disease. The amount of publications that have come out are in the hundreds of thousands. Now, I'm going to tell you that a lot of those are really poor because it has come out fast, but there's been some really good studies, and we knew a lot about coronaviruses beforehand. So we can use our past knowledge, and then we can also look at what people are publishing. That's good. Now, it's really hard when you don't have a background in reading the medical literature and the science and going through that. And honestly, I look at papers a lot. I read a lot of papers, and as Todd knows, and most of the people in the ICU, I'm pretty skeptical of most new treatments that come out, and I rip apart papers all the time and what people put out there, and go to meetings and talk to people, and you have to have that background to be able to sift through the amount of publications that are coming out.
We're reaching the end, but along those same lines, talking about treatments, ivermectin and hydroxychloroquine.
So people are asking about ivermectin and hydroxychloroquine.
Are those things that we are prescribing, and why or why not? I suppose
those are not being prescribed by us
or any other hospital in the area or nationwide. I don't know of any place that's been prescribed. Hydroxychloroquine was, everybody's excited about it in the beginning. Honestly, I wasn't that excited about it because it really didn't make a whole lot of sense. There were some early publications that supported it that have since then been thrown out. And there's been multiple publications at this point that show that it doesn't have effect both in the outpatient and the inpatient side. In fact, in the ICU, which is where I practice most of the time, it's been shown to have an increased risk of arrhythmia and death. So almost every place that initially had started using it stopped. In terms of ivermectin, there's a very strong online presence of people who are supportive of ivermectin. There's been some pretty, I'll just say, poor studies which have supported those viewpoints. But I look at that stuff on a regular basis. A lot of those studies are poorly done. They're small, they're biased. And when you really get down to it, they don't show any effect. And there's some cause of harm in some of those studies. I know there's a lot of strong feelings about it, but it's not something we're willing to do to patients in our hospital at this time.
I don't want to take up much of your time because I know you guys are busy. A couple more questions. Should people with autoimmune diseases get the vaccine?
Yes.
Now, let's say that together. Yes.
Okay, and lastly,
I'm going to back up for 1 second because we get this a lot.
Yeah.
we hear of people who have autoimmune diseases. Maybe it's lupus, maybe it's Sjogren's, maybe it's rheumatoid arthritis, and they're being told that you should not get the vaccine. That's absolutely false. You may not have the best antibody response to the vaccine,
especially if you're on immunosuppressants.
But if you catch COVID-19 and you're immunosuppressed and you've not had a vaccine, that is your highest risk population for a very rapid and a very quick decline in those patients.
And let's make this our last one for now. And again, like we said, we're going to take a bunch of these questions and find a way to answer them outside of this video. But one of them is, if you've had COVID, what is the likelihood of you getting the new variant? And along those same lines, could you have a more severe reinfection?
I'll be honest, we don't really know. We've only seen Delta for a few weeks now in this community, and the ability to look at other countries and what they experienced is also difficult. You know, the one thing we have in the U.S. and Europe and other first world countries, we actually have pretty good lab and are able to track people pretty well. But these other third world countries where Delta started, we don't have that data. Mm-hmm. And we will at some point. But we are seeing people who are getting reinfected with Delta in the hospital. I can't say how much.
But we do have a study that was out of England last week looking at people who received the Pfizer vaccine, the mRNA vaccine, and their protection against Delta. They, again, after their second shot, they were about 80 to 85% protected against Delta. So again, and those were not previously infected individuals, but again, a vaccination that gives you 85+% protection,
especially from hospitalization.
Hospitalization is tremendous.
Right.
That's exactly where we should be looking.
Yeah, I tell people all the time, what I care about is I don't want to see people hospitalized. I don't want to see people in the ICU. We got enough business. We don't need COVID. We didn't need it to begin with. We don't need it now. And it's I would love to get rid of all these patients alive and out of the hospital.
Yep. And not have to call a wife or a husband to tell them that they need to come because today is the day their spouse is going to die no matter what we do.
Yeah.
To look at a patient who doesn't have a visitor because they have COVID and we can't have them. Our nursing staff becomes their family. I think we're tired.
Yeah.
We're all tired. We're not the only ones doing it. Your entire hospital is doing this for our community. And we need some help in this regard. So we thank you for letting us talk.
Yeah.
Any final words?
Sorry for the technical glitches.
All right. And we have a lot of comments just thanking all of you and just so much support for the two of you. You guys have been such tremendous leaders through all of this. So thank you both so much.
Thank you.